Evening, everyone. Again, my name is Alicia Cook Henderson, and I'm the Youth Suicide Prevention Specialist here at DBHDD in our Office of Behavioral Health Prevention and Federal Grants. I just want to thank you all for joining us this evening. This is the first session of our 2023 Pediatric Zero Suicide webinar, and we are thrilled to bring you this first session titled Suicide Risk in Youth and How to Screen for It. And it is with great pleasure that I introduce our speaker, Dr. Dorian Lamis. Dr. Dorian Lamis is a board-certified licensed clinical psychologist and an associate professor in the Department of Psychiatry and Behavioral Sciences at Emory University School of Medicine. He provides direct clinical and administrative services in the Grady Memorial Hospital Behavioral Health Outpatient Clinic with patients diagnosed with serious mental illness and/or at risk for suicide. Dr. Lamis' research focuses on mood disorders, substance use, and suicidal behaviors in a variety of populations, including adolescents, and he has published over 150 peer-reviewed articles and book chapters on these topics. In addition, he is a senior editor of 2 books on suicide entitled Understanding and Preventing College Student Suicide and Advancing the Science of Suicidal Behavior, Understanding and Intervention. He is the Director of Education and Training at the Injury Prevention Research Center at Emory and the Associate Director of the Postdoctoral Residency Program in Health Service Psychology. And without further ado, I welcome Dr. Dorian Lamis.
Thank you, Alicia, for that kind introduction, and thank you, attendees, for being here today to learn about this very important topic. My talk is titled Suicide Risk in Youth and How to Screen for It. However, I'll go much further than just screening for it, suicide, but how to identify people who are suicidal, how to assess for suicide and determine level of risk, and then what to do from there. So first, in terms of my disclosures, I serve on a number of board of directors and advisors, as you can see there. I do some consulting work for Bristol Myers Squibb. So today I'll be talking about rates and demographics for youth suicide, and then I'll discuss some risk and protective factors as well as warning signs for suicide in youth. Then we'll move on to suicide screening and risk assessment, followed by safety planning, how to conduct a suicide safety plan, and then a brief overview on lethal means counseling, followed by referrals and the importance of documentation, and then wrap up with some summaries and conclusions. So first, suicide rates and demographics. So overall, suicide is the 11th leading cause of death in the United States. That's across all age groups and all ethnicities and everything. The suicide rate is 14.1 per 100,000, and about 48,183 people died by suicide last year. In addition to death by suicide, 12.3 million adults reported having suicidal thoughts. 3.5 million adults made a suicide plan, and 1.7 million adults attempted suicide. And these numbers are most likely an underestimate of really the scope of the problem. So suicide has historically been the 10th leading cause of death for many years. However, in 2020, COVID moved up to the 3rd leading cause of death, dropping suicide down to the 11th leading cause of death when all ages were included. However, even with COVID, suicide was the 2nd leading cause of death for youth aged 10 to 14 and individuals ages 25 to 34. And it was the 3rd leading cause of death for youth and young adults aged 15 to 24. So this talk obviously is going to focus on suicide in youth. So as you can see, from ages 10 to 34, suicide is either the 2nd or 3rd leading cause of death. So although these data do not include suicide-specific deaths, they do show the relative increase in rates of firearm-related deaths of all types, including suicide, homicide, unintentional, and undetermined death among children and adolescents. And the increase was around 30% from 2019 to 2020. So which is more than twice as high as the relative increase in the general population. So youth are dying from firearm death at an astonishing level, and which has also been increased over the last couple of years. In 2020, firearm-related injuries became the leading cause of death in youth. So this data was pulled from the CDC WISCAR's website, and it shows a decrease actually from 2018 to 2019 in youth 10 to 18 years of age. And then there was a slight increase from 2019 to 2020. And what we know from the 2021 data is there was even more increase, another significant increase from 2020 to 2021. And this study was just published a few weeks ago, showing the suicide and homicide death rates among youth aged 10 to 24 from 2001 to 2021. And what was found was that the suicide rate among this age group of 20 to 24 remained relatively stable from 2021 to 2007, and then increased 62% from 2007 through 2021. So again, this is a huge increase in this age group. The homicide rate, on the other hand, did not change significantly from 2001 to 2006, and actually declined a bit from 2006 to 2014, but then it increased 60% to in 2021. So both suicide and homicide death rates are on the rise in youth aged 10 to 24. So suicide rate broken down by gender. This is a graph showing ages 10 to 18. The male suicide rate is about 3 times the rate of females, whereas females attempt suicide more than males, and we'll get to why that is here in a bit. With regards to race and ethnicity in suicide in age 10 to 18, American Indians non-Hispanic youth have the highest suicide rate, which is followed by white non-Hispanics. White Hispanics, Black non-Hispanics, Asian Pacific Islanders, and non-Hispanics had comparable rates hovering around 5 to 6 per 100,000. So this slide shows the suicide rate from incorporating sex, race, ethnicity, and age. And as you can see, the highest rates here are American Indian or Alaskan Native, non-Hispanic men aged 25 to 34, and with a rate of almost 70 per 100,000. And this is followed by ages 15 to 24 with a rate of 60 per 100,000. These rates are 4 to 5 times higher than the national average. White non-Hispanic males aged 15 to 24 are also well above the national average at around 25 per 100,000, and Black and Hispanic males aged 15 to 24 are also above the national average, around 20 per 100,000. So suicide really affects age and ethnicity in demographic groups in different ways. Some are higher than others, but really what we've seen over the last several years is that this young to young adult age group is really increasing. With regards to COVID-19 and suicide, the data are just now kind of emerging since there is a lag of suicide rates from data that's available. But findings from this study that came out a few months ago showed that the observed monthly suicide rate was higher than expected for youth aged 5 to 24 across the first 10 months of the COVID-19 pandemic. And although there was some variation, these findings were consistent for females and males. So COVID is having an effect on youth suicide rates. looking at specific age groups, the 5 to 12 years on the 18 to 24 at the top of the left graph and the 13 to 17 at the bottom of the left graph shows the same results, that the expected suicide rates were, or the observed suicide rates were more than the expected suicide rates in these age groups. And when you look specifically at firearm suicides, the observed rates were higher than expected. So COVID definitely had an impact on youth suicide. In another 2023 study, these researchers found that the number of suspected suicides and non-fatal suicide attempts among children 6 to 19 years old reported to the United States Poison Centers during COVID were higher than the pre-pandemic period. So again, COVID is having an effect on not only suicides, but non-fatal suicide attempts. So moving from suicide rates to symptoms of suicide and as well as ideation and attempts, the 2021 Youth Risk Behavior Surveillance Study recently published its findings of 17,000 high school students. And what they found was about 42% of high school students had experienced periods of persistent feelings of sadness or hopelessness during the past year. And persistent feelings of sadness and hopelessness were defined as feeling so sad or hopeless almost every day for 2 weeks or more days in a row that the students stopped doing their usual activities. And more than half of female students reported these feelings of sadness and hopelessness, while 29% of males reported hopelessness. More Hispanic and multiracial students experience feelings of sadness and hopelessness, more so than white students and Black students. And a very kind of staggering number here is that 69% of high school students who identified as LGBTQ plus reported hopelessness in the past year. 22% of all high school students, so more than 1 in 5 students, and about 30% of females, so around 1 in 3, had seriously considered attempting suicide during the past year. So about twice as many females considered attempting suicide than males, and they were comparable. Suicidal ideation was comparable across ethnicity and race, but again, 45% of LGBTQ plus high school students reported considering suicide in the past year, which is really cause for concern. About 18% of high school students, so nearly 1 in 5, reported making a suicide plan. 24% of female students reported making a plan, and 12% of males reported making a plan. So here again, the percentages across race and ethnicity were comparable for suicide plan development. And similarly to the past 2 slides, 37% of LGBTQ plus high school students reported making a plan. And then lastly, from the YRBS, about 10% of all high school students reported attempting suicide during the past 12 months. So if you have a class of 20 students, approximately 2 of them will have attempted suicide in the past 12 months. More female students than males, so almost double indicated that they attempted suicide in the previous year. More Black students, about 14% reported attempting suicide, more than other races, including whites, Hispanics, and Asians. And then lastly, 22%, so 1 in 5 LGBTQ plus students reported attempting suicide during the previous 12 months. So these you haven't heard these statistics, I hope they kind of come as a surprise that our youth, the high school students, adolescents, children are really struggling with mental health and suicide risk, and they're considering it. And there's really a lot that could be done to identify who is most at risk and then how we can get them to the appropriate services. Similar to the increase in suicide rates during COVID, the frequency of emergency department visits with a diagnosis of suicidal ideation by age for youth 5 to 19 also increased. So if you look at this graph, there's a large increase around the time of the onset of COVID. And this finding may be due to several reasons, including increased suicidal ideation due to the lockdown, sudden reductions in social interactions and increases in loneliness, but also that children were at home around their parents more frequently. So parents may be identifying that their child is at risk and bringing them to the emergency department, especially when some of the other clinics, such as pediatric clinics, may have been closed during this time or only seeing patients during or children during or through telehealth services. So as the data suggests that I've mentioned, females attempt suicide more than males. However, males die by suicide more than females. And the main reason that this is the case is that males are using firearms more than other means when trying to kill themselves. Around 53% of all suicides occur with firearms. 27% are due to suffocation, which includes hanging, and about 12% are through poisoning or overdose. When it's broken down by male and females, adolescents, male youth die by suicide using a firearm about 60% of the time. This study was published last year, whereas females use a firearm about 20% of the time, and asphyxiation, which includes hanging, strangulation, suffocation, close to 60% of the time. So there's this paradox here in how males and female adolescents what methods they're using to try to kill themselves. So the take-home message here is that access to lethal means really matters. In fact, people, adults, adolescents who attempt suicide using poisoning or overdose only die about 2% of the time, whereas those who use a firearm to try to kill themselves die about 84% of the time. So if we can restrict and limit firearms from at-risk youth, but in particular, but across all ages in general, we really can start to decrease suicide rates. Okay, so I hope by now all of those statistics about rates and ideation, behavior, plan in youth have really driven home the point that this is a widespread, really public health concern. And again, we need to understand how to prevent suicide in our most vulnerable populations, including children and adolescents. So one step in doing this is to really understand and recognize risk and protective factors as well as warning signs. So some suicide risk factors, individual ones in youth, that these are unique in youth, are mental disorders. So if a child or adolescent has a mood and anxiety disorder, these are the kind of most common in this age group. They will be at a higher risk of suicide. But there's other DSM-5 disorders as well, including bipolar disorder, schizophrenia, but just mental disorders in general really increase the risk for suicide in youth. Hopelessness, helplessness, guilt, and worthlessness are also these are symptoms of depression, but also increase the risk for suicide. If a youth is using alcohol or substances or have an alcohol or substance use disorder, their risk for suicide will be increased. Previous suicide attempt. We know that previous suicide attempt is really the strongest risk factor for subsequent attempts. So if a youth has had a prior attempt, you really should assess and continually monitor the youth for subsequent suicidality. Disciplinary or behavior problems in school could increase risk for suicide. Sexual minority identification. So as we saw from the previous slides, sexual minority, so homosexual, bisexual, lesbian, transgender youth are all at a higher risk for suicide than their heterosexual counterparts. A sense of loneliness and isolation. This is a big one, especially what happened during the pandemic. We saw the kids not interacting with others and really having a sense of loneliness at times. In terms of social and situational risk factors, a recent or serious loss, so a death in the family, broken relationships, loss of interest in friends, hobbies or activities, family history of suicide. So if the youth you're working with, if they have a first degree relative, brother, sister, mom, dad, who have died by suicide or attempted suicide, they're going to be at a higher risk than individuals that do not have that family history. Just like mental health diagnoses, suicide tends to run in families. Child abuse and neglect. So we know especially sexual abuse and physical abuse, but also emotional abuse and neglect can increase one's risk for suicide. Family or peer conflict or violence is another factor that may increase suicide risk, and lack of social support. So whereas lack of social support may be a risk factor, I'll get to some protective factors in a bit, but the CDC really has driven home the fact that being connected to others, feeling that you're supported by friends and family is a protective factor, whereas a lack of this social support is a risk factor for suicide. Being a victim of bullying or being a bully. So this is another kind of form of violence, but what I've seen personally in my own practice, but then just through the research, which has really emerged over the last 15 years, that people, especially children who have been bullied online or in person, could be vulnerable to suicide, having suicidal thoughts or attempting suicide. And then in terms of community and societal risk factors, access to lethal means, which we'll get to in a bit, but having guns locked up, having other lethal means unavailable to a teen is going to stop their likelihood of attempting suicide or even worse, dying by suicide. There's a stigma associated with asking for help. So this may, if the youth feels stigmatized or they don't feel comfortable asking a trusted adult or a counselor for help, this could be a risk factor. Barriers to accessing services, whether this is due to living in a rural area or not having a psychiatrist, psychologist, or other mental health provider close by. This could be a risk factor for suicide. Racism and discrimination, especially among BIPOC or minority youth, can be a risk factor for suicide. Unsafe media portrayals of suicide. So there's actually a toolkit that the Suicide Prevention Resource Center has put out that shows how media outlets should really, after suicide happens, how they should depict that. And there's ways to do it that are better than others, which could lead to other people attempting suicide or dying by suicide. And then lastly, social media use. So when kids are using social media, comparing themselves to others, or trying to get likes, or they're status seeking and they don't get the likes they want, or they're again comparing themselves to others, social media really has had a detrimental effect on youth mental health and suicide risk. And recently, SAMHSA and the CDC have put out guidelines for social media use in adolescents, which I encourage you to check out. And this list is not an exhaustive list of youth suicide risk factors. However, these are some of the most important ones, I think. And I just want to note that if a child has one or two of these risk factors, it doesn't mean that they're going to be suicidal. It just means that this is something that you need to look out for, monitor, ask the child about. So the opposite of risk factors are protective factors. These are reasons why someone would not attempt suicide or think of suicide or die by suicide. So skills in problem solving, coping skills, conflict resolution, these are modifiable that can be learned and taught in therapy, for example. So I mentioned earlier the strong connection to family, friends, and community. So social connectedness is a really strong, probably the strongest risk, protective factor for suicide. Having a stable environment. So kids who have, they have housing, they have financial resources, their parents are supportive, they are in a loving environment, really can serve as a protective factor for suicide. Responsibility to others, pets. So if a child feels responsible to, for example, a pet that I've seen it many times before, could be a protective factor for suicide. Limited access to lethal means. Again, this keeps coming up, and there's a whole section about this a little later. But really, limited access to lethal means in children and adolescents is important. Having a meaning and purpose in life. So when a youth feels like they're waking up in the morning, they have meaning, they have purpose in their own life, that's going to be a protective factor. Whereas if they don't have that, it could serve as a risk factor. There's cultural and religious beliefs that may discourage suicide. And I think one important thing is accessible and effective clinical care. So mental health care, physical health care, and substance use disorder treatment if necessary. But having these services accessible will serve as protective factors for suicide. And similar to risk factors, this isn't an exhaustive list, but these are some of the most important protective factors. So lastly, some warning signs. And just to be clear, warning signs are different than risk factors. Warning signs indicate an immediate risk of suicide, whereas risk factors suggest someone is at a heightened risk for suicide, but not necessarily in crisis. So another way to understand this is that risk factors increase the probability a suicide crisis will occur, whereas warning signs indicate a suicidal crisis has already begun. So things to look out for youth suicide warning signs is if the youth all of a sudden becomes irritable, angry, or hostile, if they all of a sudden withdraw from friends and family, if they have a loss of interest in activities that they used to enjoy doing, if a youth is talking or writing about suicide, for example, making statements such as "I'm going to kill myself" or I won't be a problem for you much longer." So feeling like if they are dead, they will somehow alleviate a burden on other people in their death. Poor school performance if grades just start to fall off, tearfulness or frequent crying, restlessness and agitation, fatigue if their energy levels just go from normal to very low, any changes in eating or sleeping habits, trouble concentrating in school, at home, or just in general. If there's any unexplained aches or pains, or if a child has headaches all the time, which really cannot be explained by any other reason, it could be a warning sign. Mood swings, so going from really happy to really sad, but also if there's mood has a drastic change. So, like for example, being in a depressed mood and then changing to a hypomanic or hyper or manic episode, which could indicate a diagnosis of bipolar disorder, but may also be a warning sign for suicide. Any misuse of alcohol or drugs, if the child or adolescent starts to give away their belongings or prized possessions, and then risky, self-destructive, or impulsive behavior. So if they're doing things like driving drunk or other kind of risky behaviors, they're not really caring about the consequences. This can be a warning sign for suicide in youth. Okay, so we know the rates of suicide and the demographics. Those are some I just discussed, some risk and protective factors and warning signs. But now that you know these things, what do you do? How do you screen a youth for suicide? And then after the screening, how do you do a more comprehensive suicide risk assessment? So first, it's important to understand the difference between screening and assessment. So suicide risk screening the goal is to identify individuals who are at risk for suicide. This can be done by asking questions or having a youth complete a survey, paper, pencil, or through a computer. The goal, again, is to identify youth at risk for suicide. In terms of assessment, this is a comprehensive risk evaluation. This is to confirm risk. So you've identified them, now you want to confirm their risk and determine what level of risk they're at. You want to estimate their imminent risk and danger to themselves. And then the risk assessment also guides treatment planning and next steps in the care of the child or adolescent. So why is it important to screen for risk in medical settings, such as pediatricians' offices? Well, the majority of those who die by suicide have had contact with a medical professional within the previous 3 months. In fact, around 80% of adolescents visited a healthcare provider within the year prior to their suicide death. 49% of youth had been to an emergency department within 1 year of their death, and 38% of adolescents had contact with the healthcare system, within 4 weeks prior to their suicide death. So the message here is that these children and adolescents are coming into pediatricians' offices, to other healthcare providers prior to their suicide death. So it's important to recognize warning signs, to recognize risk and protective factors, as well as screen for these kids and understand what their level of suicide risk is. So one thing at the on a continuum on the far left side of the continuum, the kind of lowest thing you could do is screen specifically for suicide by asking directly a few questions. And regarding suicidal thoughts or ideation, you could ask, are you having thoughts about suicide? You really want to be direct. And if they answer yes, how often do you have these thoughts? You want to know the frequency. It's different people that think about suicide 20 times a day versus people that have passing thoughts once a month. So understanding the frequency. How often do these thoughts last? So the duration of their suicidal thoughts. You can ask on a scale of 1 to 10, how intense are these thoughts? How serious do you feel about carrying out these thoughts? And have you thought about how you would kill yourself? So essentially, do you have a plan? And if yes, how would you do that? So understanding if they have a method and if they have access to the methods. In terms of suicidal behaviors, you could ask, in your lifetime, have you ever attempted to kill yourself with some intent to die? How many times have you attempted suicide? And when did this happen? So again, it's different from a kid that said, that's 19, that said they attempted 6 years ago versus someone that attempted 2 months ago. And then understanding how many times it happened. As I mentioned before, a prior suicide attempt is a strong predictor of future suicide attempts. So just understanding if they had a suicide attempt, but then the nature of the actual attempt and how were they hospitalized? Did they, was the attempt near lethal? So learning about those by asking direct questions is important. One of the biggest myths in the suicide literature is that talking about suicide or asking somebody about suicide will make the person feel suicidal or will encourage suicidal thoughts or attempts. And there have been numerous studies showing that that is not the case. These studies have shown that asking at-risk individuals about suicidal ideation is not associated with subsequent increases in suicidal ideation or attempt. And here are just a few of the studies that, again, these range back 15 years, but there's many, many studies showing that asking about suicide will not make someone become suicidal. So if you are uncomfortable asking, you really should kind of get over that and learn and understand that asking about suicide can in fact save somebody's life and is not going to do anything to increase the risk for suicide in youth or adults for that matter. So there's several suicide screening instruments. In this talk, I'm going to discuss 3 of the most commonly used ones. The Ask Suicide Screening Questions, or the ASQ, the Patient Health Questionnaire 9 for adolescents, the PHQ-9, and the Columbia Suicide Severity Rating Scale, which you may be familiar with these. A lot of them are embedded into electronic medical records. So first is the Ask Suicide Screening Questions. These are endorsed by the National Institute of Health. They are openly available. The left is a paper version and the right is how it looks embedded into the electronic medical records. So the questions on the Ask include, in the past few weeks, have you wished to be dead? Yes or no? In the past few weeks, have you felt that you or your family would be better off if you were dead? In the past few weeks, have you been having thoughts about killing yourself? Have you ever tried to kill yourself? And then are you having thoughts about killing yourself right now? So these, again, screening questions to identify if the youth is at risk. So going a bit further, there's the ASQ toolkit available online at the NIH website. It's actually organized by medical setting. So the third one down there is the outpatient primary care specialty clinic. So this would be like a pediatric clinic. You can get the ASQ tool, their brief suicide safety assessments, information sheets, scripts for staff, flyers for guardians, patient resources lists, and educational videos. So it's really a good package that you can download from the NIH website. And the ASQ is used all over the country in many medical settings. So the next screener or and an instrument that's often used as a screener is the PHQ-9. It's a 9-item depression screening assessing symptoms during the past 2 weeks. It's available in the public domain and commonly used in medical settings. There's one suicide question. It's item 9 of the 9-item scale. The question asks, how often have you been bothered by the following symptoms during the past 2 weeks? Thoughts that you would be better off dead or hurting yourself in some way. So what the research has shown looking at suicide risk screening through the patient health questionnaire is that it is really not a good screener for suicide risk. It's good for symptoms of depression, but the one item of the PHQ-9 is not a good screener in across the board, but especially in youth. So, for example, this study in 2021 examined 600 pediatric medical patients who completed the ASQ and the PHQ-9, and 81 participants who screened positive for suicide risk, or 81 participants screened positive for suicide risk, and 39% of those did not screen positive for depression, and 56% did not endorse the PHQ adolescent item 9. But more importantly, nearly 1/3, so 32% of participants who were positive for suicide risk screened positive only on the ASQ, and they were negative on the PHQ-A, and did not endorse the item of the single item on the PHQ-9. So these findings suggest that although depression and suicide risk are strongly related, a significant portion of pediatric medical patients at risk for suicide may pass through the healthcare system unrecognized if depression screening, such as the PHQ-9, is used as a proxy for identifying suicide risk. So in short, if you're using just the PHQ-9 and you are thinking that this is a good method or approach for suicide risk, it really isn't. And there are other alternatives. One being the combining the PHQ-9 for adolescents with the ASQ. This is a really good way of accurately screening youth for depression and suicide. And there's been research evidence backing this approach and should be considered. So here I'm going to move on to the last screener, which is also good. It is the Columbia Suicide Severity Rating Scale screener. And questions here include, have you wished that you were dead or wished that you could go to sleep and not wake up? Have you actually had thoughts of killing yourself? Have you been thinking about how you might do this? Have you had thoughts and had some intention of acting on them? And have you started to work out or worked out the details of how to kill yourself? And did you intend to carry out this plan? And lastly, have you ever done anything, started to do anything, or prepared to do anything to end your life? And as you can see under the past month screener, there's either yes or no. And if the youth fills in yes to answer two, then you ask them 3, 4, 5, and 6. And if they say no to question 2, you go down to item 6. But you could determine low risk, which is the yellow, moderate risk, which is the orange, and high risk, which is the red. And then it shows underneath possible response protocol for if they are in the different risk determinations. And if they're moderate or high risk, the provider must complete a full suicide risk assessment and determine next steps. This flowchart illustrates an approach to assessing the safety of an individual with suicidal thoughts. It's based on the CSSRS to guide decision making, while also asking about suicide risk and protective factors. So on the right side is essentially the questions on the CSSRS screener, but it's a flowchart in what you need to do and how you can get the youth to the appropriate level of care. And then on the left side are several risk and protective factors that you can also consider when making a clinical judgment on their level of risk. Okay, so moving from screeners to actual risk assessments, the brief suicide safety assessment, which is kind of coupled with the ASQ, is on the left, and on the right is the full Columbia Suicide Severity Rating Scale. So the BSSA, or the Brief Suicide Safety Assessment, has 6 steps. The first step is really praising the patient, praising the youth. So saying, I'm here to follow up with you on your responses of the suicide risk screening. Again, they've screened positive for suicidal risk. These things are hard to talk about. Thank you for telling me. I need to ask you some more questions. The second step is really assessing the patient, so asking frequency of suicidal thoughts, and there are several prompts under this section, asking about a suicide plan, and then past suicidal behavior. Then assessing the patients in terms of symptoms, so there's a list of symptoms, including depression, anxiety, impulsivity, hopelessness, sleep pattern, appetite, other concerns. And then you ask about social support and stressors, so things like family situation, social support network, school functioning, bullying, suicide contagion, or reasons for living. Then you really want to interview the child with his or her parent or guardian together. So you're essentially trying to get collateral information. The child may not readily disclose their suicidality to you. So asking their parent if they've noticed changes in their child, if the child is disclosed to them if they are thinking about suicide. So interviewing them together, and then making a safety plan. And I'm going to get to the importance of the safety plan in a bit, but really discussing coping strategies, means restriction, and asking safety questions. Determining disposition. So for the positive streams, follow up on the next appointment if possible. What level of risk are they? Do they need emergency psychiatric intervention? What is the treatment plan? What is the level of care that's appropriate for a specific child or adolescent? And then providing resources to all patients, including the 988 number, other resources that are specific to your area. So the CSSRS is another great assessment protocol. So here is what it looks like embedded into the electronic medical records. So you're asking again the wish to be dead, non-specific, active suicidal thoughts with any methods, and then suicidal ideation with some intent. So this full version gets much more detailed than the screener. It also asked about suicidal behavior, both lifetime and past 3 months. So asking about if they made an attempt, getting the details of the attempt, how it happened, what method did they use? Do they continue to have the method? Did they have any interrupted suicide attempts, any aborted or self-interrupted attempts? And then have they made any preparatory acts or behaviors? And then, so really understanding ideation and behavior using the CSSRS is it's one of a lot of people think it's a gold standard for assessing suicide risk. But again, I think the ASQ or the CSSRS are both really good options. Here's a youth screening suicide pathway using the ASQ screener and then the brief suicide safety assessment. So going down, question by question, and then determining a outcome and a disposition of level of risk. This flowchart could be used also with the CSSRS and the CSSRS rating scale. So if you see at the bottom, the safety planning that's circled is a important component of what you do after a risk assessment or during a risk assessment. Okay, and lastly, you may have heard of the SAFE-T, so the Suicide Assessment 5-Step Evaluation and Triage. The purpose of this tool, which can be used with adolescents, is to guide healthcare professionals through 5 steps of comprehensive suicide risk assessment, identifying risk factors, noting that these could be modifiable to reduce risk, identifying protective factors, noting those that could be enhanced, conducting the suicide inquiry about suicidal thoughts, plans, behaviors, and then determining level of risk intervention, including a table to guide clinicians in determining high risk and low risk, which is on the next slide. And then, but the last step is documenting, and really how important it is to document risk and your visit with a suicidal youth. There's a pocket card for the safety that kind of is available online for free, and it reminds healthcare professionals of what needs to be done with these steps. This is what step 4 risk level determination looks like. So to help you determine low, moderate, or high risk, consider risk protective factors, current and previous suicidality, and then what interventions may need to be taken to keep the youth safe. Okay, so with the screening and assessment approaches that I just showed, all of them had a component of safety planning. And safety planning is very, very important to keep your patients, children, and adolescents safe. What is a safety plan exactly? It's a game plan for what you do in the event of significant distress or suicidal crisis to avoid unsafe behaviors. A safety plan can give a patient a sense of control over suicidal thoughts and strong emotions. It is not a safety contract. Lots of research has shown that safety contracts do not work. You really have to use and implement a safety plan. But it's important to note that a safety plan is not a guarantee that the patient will not try to die by suicide. Safety planning must include appropriate assessment and risk factors and patient reliability. So it's really just being preventative. So an ounce of prevention is worth a pound of cure. So the safety plan incorporates 4 elements of evidence-based suicide risk reduction strategies. The first one being reducing access to lethal means, teaching brief problem solving and coping skills, enhancing social support and identifying emergency contacts, using motivational enhancement to increase the likelihood of engagement in further treatment. So the safety plan includes 6 steps. The first step is warning signs. So you want the youth to write down and understand what thoughts, images, moods, situations, behaviors that may cause a crisis. Then you want them to come up with internal coping strategies. So these are things that they can do in the event that they start to think about suicide or become suicidal. What could they do on their own to cope with these thoughts? The third step is identifying people or social settings that provide a distraction. So the youth would not disclose their suicidal thoughts to this person or in the social setting. This is people that they can go to for general support. The third, or I'm sorry, the fourth step is these are people who they can ask for help. So these are actual individuals, friends, family, clergy, whatever, that they can ask for help in the time of crisis. So they will be disclosing their suicidal thoughts in this step. And you want these people to be people that the youth trust and can feel comfortable disclosing these thoughts. The fifth step is identifying professionals or agencies that they can contact in the event that they become suicidal. So mental health professionals, suicide hotline, their PCP, whoever it is, these are mental health professionals that they can contact. And the sixth step, and some would argue the most important step, is really making the environment safe. So what can they do in conjunction with their family members and to make the environment safe? So this is an example of a safety plan completed with an adolescent. So this person said that their personal warning signs were, when my parents start arguing, when I'm stressed about school, when I feel like I'm a burden on my family, or when I'm sad about life. So these are warning signs. The coping strategies that the youth came up with was I can play with my dog, play video games, doodle in a notebook, read my favorite book, draw and paint. People that they came up with is my best friend Ashley, my friend Jacob, Aunt Sally, Uncle Tom, again, friends and family members. The places they could go, my neighborhood pool, Ashley's house. Step 4, this is adults that they could ask for help. So coaches, relatives, pastors. Step 5 is in professional help, so calling their therapist, suicide hotline, suicide text line, 911. It could be a pediatrician, a PCP, but again, professionals that they can call. And then also writing down their reasons for living. So I want to go to college, be an engineer, to be a role model for my little sister, our little brother. And then their to-do list. So right away, this adolescent is going to make the home safe. They need to lock up or remove the following items from the home: dad's hunting rifle, medications, with the help of the parents. So it is very important to have the parents on board with these suicide safety plans. And they need to write down the numbers of everybody that's on their safety plan. So just so they have them. One of the most important things about safety plans is having it accessible in the time of crisis. There's many safety plan apps available. Given that kids are always on their phones, I think apps are really probably the best option here. So on the left is the safety plan app. On the right is the My3 safety plan app. Again, it's the same thing I was just talking about, but on their phone that they can pull it up. Another good safety plan app is called Beyond Now. I would say those are three of the best ones, but having them really buy into the safety plan and use these apps to have them close by if they become suicidal is important. So I keep mentioning involving the parents and family in safety planning. So you want to share the safety plan with parents and encourage the use. You want to provide some psychoeducation around warning signs and triggers to parents, promoting connections, listening. You want the parent to listen and validate child's thoughts and feelings about suicidal thoughts and behaviors. Having the parent develop their own social network or people to contact in crisis or emergency. So if their child becomes suicidal or mentions that they're thinking about suicide, who's on the parents list to reach out to? Parents need to remove the lethal beads. It's their responsibility in most cases, given that kids cannot usually buy firearms, for example. So removing the lethal means, supervising and monitoring the child's behavior, including social media accounts, and then connecting to treatment services. Obviously, the parent needs to be involved in that as well. So the suicide safety plans, there's a lot of research behind them. There's not quite as much research in youth. However, there are several 15 to 20 studies on safety plans in youth. This study came out a couple of months ago. It was a systematic review looking at what the evidence shows for the effectiveness of safety planning for children and young people. And what was concluded was that the current evidence suggests that safety planning should be a routine part of care packages for children and young people with suicidal ideation proportionate to their needs. So, really implementing these suicide safety plans in your practice with at-risk youth is critical. All right. So moving on to lethal means counseling, which is associated with safety planning, especially the lethal means restricting or reducing lethal means. But lethal means counseling is another evidence-based strategy, which was developed to assist clinicians and other healthcare professionals to approach lethal means counseling with an informed, collaborative, and respectful attitude. It's explicitly anti-suicide, but it's neither anti nor pro gun or anti or pro medication. So, it's not a political thing. It's really just anti-suicide and how you can make make lethal means inaccessible to youth and especially at-risk youth. So the overview of lethal means counseling, the first is obviously you've assessed suicide risk using one of the standardized risk assessment tools I mentioned. You have then explained risk to the patient and parents or support people. Suicidal feelings can come and go. Reducing access to lethal means, especially firearms, can keep the youth safe. Collaborate on the plan to reduce access to lethal means, leading suicide method, firearms are, and medications, though, which is the leading method of attempt, as well as any method that the specific ideation focuses on. Agree on the role and timetable and document the plan and the chart. follow up within 24 hours or the next day of school in a school setting, and a next appointment about lethal means. So the premise behind CALM, the Counseling on Access to Lethal Means, is that means restrictions, so an individual will either substitute a less lethal method and the attempt will be temporarily or permanently delayed. So fewer attempts will prove fatal, and the suicidal crisis will pass for many, given the acute period is often short. So research has shown that 24% of kids who report 24% of people report taking less than 5 minutes from the decision to take their own life to the attempt. And 70% say that it is within an hour from decision to attempt. So, and moreover, 89 to 95% of attempters do not go on to die by suicide. So it's really through this, the suicide rate will drop, and it's driven by the decline of rate of suicide by the restricted method, specifically guns. General general steps of CALM after you first identify the youth who would benefit from lethal means counseling, and then identify possible means of self-harm that are available to the individual, ask about their access to lethal methods, and then work with the youth and their family to reduce access to lethal means, such as safe storage of firearms. And this, again, is just kind of a brief introduction to CALM. I do want to draw your attention to a free online CALM training, which is put on by the American Academy of Pediatrics. It's all at their website. It's 1 hour. You receive one CME credit upon completion, but it's specifically for pediatric providers and how to counsel a youth who is suicidal and may have access to lethal means. So I definitely encourage you to check out and register for this online training, which is available through 2025. All right, so the last section here is really the importance of referrals and how to make transitions with at-risk youth, and then the importance of documentation. So in terms of safe care transitions, you really want to develop internal and written policies and procedures in your clinic for safe care transitions. So when the youth is referred to a provider or service both within and outside your organization, there are steps that should be taken. Also, when the youth transitions to an organization or provider in the community, or when they terminate services either independently or in agreement with the care provider. Staff should be trained on the policies and procedures for safe care transitions, and you really want to ensure that youth and parents receive education about the model of care and the rationale for treatment as they move from one agency to another, and monitor to ensure the care transitions are documented and flagged for action in the electronic medical record. Creating smooth care transitions, as I hope you understand now, establishing a safety plan with you and providing a copy before referral, ensuring that the youth and parent has spoken by phone with the youth, with the new provider, call and send all relevant patient information, which could include treatment planning, can include the safety plan, what else you've done with the youth, a warm transition if possible. If you have a mental health professional on your in your clinic, within your clinic, or on your floor, really doing a warm handoff. So bringing the youth to the mental health provider really helps in getting them comfortable with coming back, getting them comfortable with disclosing their suicidal ideation. And then contact the youth or the parent within 24 to 48 hours after they've transitioned to the next provider and document this contact. So just briefly wanted to show a few of the evidence-based treatments for suicidality. As pediatricians, you most likely would not be doing this. However, it is important to really understand what evidence-based treatments specifically target suicide risk and have been shown to be effective for youth suicidality. These include dialectical behavioral therapy, cognitive behavioral therapy, CBT in general, but there's also CBT specifically for suicide. It's called CBT SP, suicide prevention. Then attachment-based family therapy, as well as the collaborative assessment and management for suicidality, or CAMS, which is a protocol which has been shown to be effective in reducing suicidal ideation in children and adolescents. So I'm sure you know this, but I need to just mention the importance of documentation. So when you're documenting a youth suicide risk, you really want to document the pros and cons of your decision for next steps. You want to document all youth contact, including phone, email, text. Document using the youth's own words. Document as close to contemporaneously as possible. Document all contacts pertaining to youth, so parents, school. Document review of medical records, and then include in the safety plan, or include the safety plan in the documentation. So, if documenting is important for subsequent providers, but also important if something tragically happened to the youth, you have put this in the medical records, and it could help you in terms of any legal liability in the future. So documenting all of the contacts with youth or family and friends is really critical. Okay, so wrapping up here, so some summaries and conclusions. I really hope if you didn't know before, you do understand now that suicide in youth is a major public health concern. In order to prevent youth suicide, you really need to know the risk and protective factors and warning signs for youth. You need to conduct a suicide screening and risk assessment, and do one that has evidence behind it. It's evidence-based, such as the ASQ screener or the CSSRS. Developing a safety plan is important. Implementing lethal means counseling and removing firearms or other lethal methods from the environment. You really need to try your best to engage and involve the youth family, ensure safe and smooth care transitions, with the goal being a warm handoff if you could do that. But at the very least, just making sure that the youth gets to the appropriate services in an effective way, and refer to providers who use evidence-based treatments. So really understanding who are the high quality psychologists, psychiatrists in your area that you can refer to, having a list of those people that practice evidence-based interventions, and they have experience working with suicidal youth. And then lastly, again, document everything. It's very important. Okay, so that's all I have. Thank you for remaining on with me here, and let me know if you have any questions.